Hello everyone, welcome back to another session in dentistry and more. Let's continue our question paper discussion of public health dentistry. Today we have part 3, last 2 sessions. Hope you guys watched it. Part 1 was about the beginning chapters, introduction, then waste management and water purification. And the second session was the most important one. It was about epidemiology. And this part we included epidemiology of dental caries, epidemiology of periodontal disease and epidemiology of oral cancer. So by now you are well familiar with the term epidemiology. So last session was highlighting the general epidemiology. Now we are focusing the epidemiology of dental caries, periodontal disease and oral cancer, the three main problems of oral cavity. So last session we were focusing on the tools of epidemiology, how the study design, how we can plan a study, so all those things. But now we are into the application level of epidemiology. So the first chapter, epidemiology of dental caries. The most commonly asked question is about the epidemiological triad of dental caries, and sometimes the question will be there, add a note on time factor. Actually this is the fourth factor, and sometimes for dental caries this is known as epidemiological tetrad when we include time. So you need to write the definition similar to the last one. So in epidemiological triad, this also we had seen in public health. We have agent, host and environment factor. But for dental caries, we have a time factor, which is a fourth factor. So in host factor, that is related to the person, there are many factors which involving dental caries occurrence in a person. Depends on the race and ethnicity. Some race is having more predilection. Age group, the teenagers having more dental caries. Sex, the female gender is having more predilection for dental caries because of the fondness to sugar and the hormonal problem. Family history, they say bad teeth run in family. Emotional disturbance, it is linked to the overeating of sweets. Diet and nutrition, more refined diet will cause more caries. Socioeconomic status, caries is highly seen in the affluent sector, that is the upper class families. And related to the tooth, that is the composition of tooth, hypomineralization, so all those things. Saliva is a defense mechanism. If saliva buffering capacity is not good, if saliva flow rate is not good, then the caries will increase. Then the agent factor, which is coming from outside, that is diet and microflora. Actually diet or nutrition is coming in all the three factors, because we just cannot put the diet into a single factor. So in agent factor, microflora, that is the streptococcus mutans, and diet. Okay, so diet, we have again the keriogenic diet, the diet which has more of refined carbohydrate, and environmental factors like geographical variations, latitude, distance from sea, coast, sunshine. Sunshine says that it is essential for vitamin D. Vitamin D is for calcium metabolism, and it is helping to reduce the dental caries. It's all indirect effect. There is no actual causal relationship. Proven relationship is not there. Like temperature, humidity, rainfall, fluoride, water hardness, trace elements, soil urbanization, all comes in. Environmental factors, nutrition, so I said it is there in all three sectors: agent, host and environmental factors. And social factors all comes in environmental factors. When it is asked for a long essay, you need to explain or elaborate a little bit of each subheading. Same question was asked in July 29. Then the short essay. Sometimes the question will be of prevention, various measures for prevention. Sometimes it will be under primary, secondary or tertiary prevention of dental caries, or sometimes it will be prevention at individual, community and professional level. So we need to write under primary prevention, health promotion and specific protection. This is secondary, early diagnosis and prompt treatment, and tertiary, disability limitation and rehabilitation. So this is to prevent disease, this is to halt the progression of disease, this is to rehabilitate already dead tooth like non-vital tooth, or to replace the tooth. So prevention by definition, we know it is the action taken prior to the onset of disease. Actually the disease is not happened in primary level, okay, whereas secondary prevention disease has happened but we are stopping the progression. Okay, so truly speaking, only the primary prevention is the actual prevention. So here in health promotion, we plan that we educate the patient, we educate them about plaque control, caries activity test, and we can apply the fluorides, fit and fisher sealant, fluoride programs, all those things. Secondary prevention is actually not a prevention, but we are preventing the patient from a gross damage, so we can restore the cavity. In tertiary prevention, we can go for complex restorative treatment like root canal treatment, pulpotomy, all those things. So one of the short note asked from this chapter is Snyder's test. Is a Caries activity test. The principle is formation of organic acids by the bacteria in a carbohydrate medium. So we are inoculating saliva and the saliva which is assumed to have the organic acid in a artificial media, which has a bromocosol green indicator which changes the color of the saliva or solution based on the pH. Okay, so first what we do is we incubate this at 37 degrees Celsius and we wait for 3 days. That is, reading will be taken after 1 day, 2 days and 3 days, and we are checking this one, how fast it is changing green to yellow. So green is a higher temperature, yellow is a lower temperature, that is it's getting more acidic. This is 5.2 and this is 5.4 and this is 2.8, sorry 3.8. So we mix the agar medium, bromocosol indicator and saliva and we wait. If this is happening, yellow is happening within 24 hours, there is marked susceptibility. If it is not happening, we still incubate at 48 hours, and if it happens at 48 hours, there is definite caries susceptibility, and still it is green, we can still incubate for 72 hours. If it is happening at 72 hours, we can say it is just limited caries susceptibility, and if it is still green, we can say the person is caries inactive. Now the next short note is Karyogram. It is a software tool and it is the best tool to assess the caries risk of a patient because it includes all the factors. Okay, all the factors which can attribute to dental caries. So it was given by Radilology. So there are 5 factors involving in Karyogram pie chart. So this is a 360-degree pie chart and 100%. We have 5 colors, that is green, dark blue, light blue, yellow and red. So these 5 colors constitute a 100% a pie diagram, and what we are checking here is the amount of green which is left, okay, or which is not created by the other 4 colors. So we have questions for these 4 colors, that is dark blue which is regarding diet frequency and content, light blue regarding the fluoride program, saliva and its frequency, yellow is regarding the past caries experience, red is regarding the plaque and mutant streptococci. And we have questions for each category, and each questions person will reply and we quantify it, we enter the values into the computer software. Then regarding each sector there will be a percentage. Okay, so this percentage will constitute a certain percentage and there will be one color, that is a green, will be remaining. So if the green is bigger, it says the patient has higher chance of Avoiding dental caries, that is his risk of dental caries is less. If the green sector is lesser, if patient is having more chance of dental caries, that is chance to avoid the dental caries is less, because all other factors are promoting dental caries. So if it is getting bigger, means the green will be getting smaller. So we are checking finally the green color. So only 4 colors will be asked. The questions for the 4 colors will be asked and quantified and put into this pie chart, and finally the remaining portion will be shown as green, and the width of green pie will be describing your caries risk. Bigger one, less caries risk; smaller one, high caries risk. Next question is caries vaccine. Caries vaccine, we know it is not at all a feasible one, because caries is a multifactorial disease. So caries vaccine is aiming at one of the factor of this multifactorial concept, that is, it is aiming at only agent factor, that is mutant streptococci. So even if we prevent mutant streptococci, all other factors are there which are beyond the level of beyond the approach of vaccination. So here there is no much relevance for vaccinating a person which is a multifactorial causation. Still, people have tried this caries vaccine, and when the question asked caries vaccine, you need to write about a little bit about the concept of immunity and what is active and passive immunization. And caries, as I said, is a multifactorial disease. So all these methods can be used for vaccine administration, that is periglandular, salivary, root, parenteral, oral submucous, ingestion of whole bacteria, murine monoclonal antibody, immune bovine milk, yolk antibody, and replacement therapy. All these can be used. One of the question was karyogenic and karyostatic element. So karyostatic element, it was given by Navio J.M. in 1972. Karyostatic means which prevents the dental caries, such as fluorine and phosphorus. And we have classification for mildly karyostatic, doubtful, caries inert, and caries promoting. Selenium, magnesium, cadmium, lead, silicon, all these are promoting dental caries. It was asked once, not very important. Now let's move to the periodontal disease, epidemiology of periodontal disease. So the question was define dental plague, plague control, and most commonly there will be question either mechanical plague control or chemical plague control, and the prevention at individual, community, and professional level. So dental plague, as you all know, it is a structured, resilient gray substance that adheres tenaciously to the intraoral hard surfaces, including removal and fixed restoration. So mechanical plaque control is mainly using the mechanical devices such as toothbrushes, interdental devices, etc. So mostly asked, or you need to write about toothpaste to identify, that is a component, the weightage, and the material used, and the purpose. Sodium lauryl sulfate is a detergent, calcium carbonate is abrasive, binder will be there, colorant will be there, flavoring agent will be there. And we can write about the types of toothbrushes, interdental aids for gingival stimulation. Whereas a chemical plaque control, we have different classification that is coming in next slides. And this is a common in epidemiology question for dental caries, periodontal disease, and oral cancer. This is regarding the prevention. Okay, when prevention of these conditions or this disease asked, you need to draw this table, that is primary, secondary, and tertiary prevention, and you need to draw about health promotion, specific protection, early diagnosis, disability, and rehabilitation, and what is given under each heading, that is by the individual, community, and professional. Okay, so this is true prevention. Disease has already occurred in secondary, and we are preventing the exacerbation, and tertiary is just like disability, limitation, and rehabilitation. So this is regarding the prevention of periodontal disease. Same will be there for oral cancer. So sometimes question will be like this: the role of toothbrush in plaque control. that is mechanical plaque control. We need to write the definition. And parts of toothbrush, all must be knowing: handle, head, tufts, shank. And regarding the ADA specification, the 1 to 1 by 4 inch long, 2 to 4 rows of bristles, and the inches tufts, that is 5 to 12 tufts per row and 80 to 86 bristles per tuft. And brushing techniques, you can write about brushing techniques: roll method, vibratory, circular, vertical, horizontal, physiological, scrub, bath metal, all are there. I uploaded one video regarding the demonstration of each technique. I'll put it in the I button. You can have a look on the brushing techniques. It will be very helpful. The next question is same, the plaque control, but it is again the mechanical plaque control. It was asked in 2016. You can write about the toothbrush, toothpaste, and these devices. Whereas in chemical plaque control, we need to write about the cationic bisbigonides, that is chlorhexidine, its substantivity, that is 5 hours in a single rinse, that is the ability to retain the active agent in oral cavity. And at low concentration, it is bacteriostatic and bactericidal at high concentration. Its working mechanism, it prevents pellicle formation and prevents absorption of bacterial cell wall on tooth surface and prevents binding of mature plaque. Then in chemical plaque control, we have essential oil rinse like thymol, eucalyptol, menthol, listerine, even antibiotics such as vancomycin, erythromycin, enzymes such as mucinase. These enzymes are able to break down the matrix of plaque. Then quaternary ammonia compounds such as benzethonium chloride and triclosan is some other agent, and delmopinol, which interferes with plaque matrix and causes a weak binding of plaque to tooth. So all are coming under chemical plaque control. Okay, so only two questions will be asked, mainly chemical or mechanical. Sometimes the short notes, dental flows. Dental flows is a thread which helps to remove the food and food particles between the teeth. So there are two methods, spool method and the circular method. We need to use a 12 to 15 inch length using a thumb and index finger and half inch of close between the fingertips, and types are nylon, silk, rubber, plastic, waxed, unwaxed, based on the flavor. Then oral irrigators, it is the use of forced intermittent steam of water. Okay, this is also known as hydrotherapy, which is actually proven to be very useful as an adjunct to toothbrushing, but never a substitute. Okay, so it is an adjunct. It is giving a better outcome. You just cannot replace the toothbrushing with oral irrigators. So it removes unattached debris, reduces the number of microorganisms because of this flushing action. You can use it in a reduced interdental papillae and for FPDs and orthodontic appliances. And contraindication, patient who require antibiotic premedication, for deep periodontal pocket, for acute necrotizing ulcerative gingivitis. In all those conditions, it is not advisable. Chlorhexidine, we know it is a digluconate acetate hydrochloride salt, 3 forms, and this bisbigoniide antiseptic is a strong base and it is dicationic, and at pH level 3.5 makes it extremely interactive with anions, which is actually its efficacy. Okay, and it is bicationic reagent, and one cation will be attached to the tooth surface and other cationic end will be acting with these anions, and this effect is known as pin cushion effect. And its usage is rinsing for 60 seconds twice per day with 10 ml of 0.2 percentage, that is 20 milligram. Okay, so it can be used in the absence of normal tooth cleaning. It is proven that it inhibits plaque regrowth and the development of gingivitis. Next question is regarding the oral cancer. It's not very important, but sometimes as a bouncer the questions will be asked, so never skip this chapter. This was a question asked various forms of smoking and smokeless form, because 72% of the smoke form are BDs and 12% of cigarettes. Then these have varieties and smokeless foam, pan, kaini, mysteries, the mawa. Many varieties are there. You need to write about it. And one question was regulatory approach. That is, regulatory approach means uh, by the laws, by the government laws, how we can prevent the oral cancer. It's a very difficult one. In India, Cigarette Act was passed in 1975 and Cancer Program in 1985. In 2003, the Landmark Act, COPTA, that is cigarettes and other tobacco product, came in, which prohibit the advertisement, supply and distribution and other products. And to 2004, WHO FCTC Convention of Tobacco Control happened. And this was a question asked for last year question, that is 5 A's of tobacco cessation, that is ask, advise, assess, assist and arrange of tobacco cessation counseling. You need to explain a little bit about this. Okay, you can ask about the patient's habit, you can advise, you can assess the patient's status of smoking, you can assist patients in quitting the habit, and you can arrange the replacement therapies, that is nicotine replacement therapy. Nicotine replacement therapy, we have gums, patches, inhaler, nasal spray and lozenges. And 5 hours of counseling. Those who willing, unwilling to quit, can prompt them to will. We can create a will to quit. That is, we need to teach them about the relevance of quitting, risk of continuing the tobacco use, rewards of quitting, roadblocks to quitting, and repeat the same at each visit. Okay, this is for the tobacco cessation counselor. So that was all about the session. So we discussed about the epidemiology of periodontal disease, epidemiology of oral cancer, and epidemiology of dental caries. So essay question will be coming, like epidemiology of dental caries or periodontal disease. Write about the epidemiological triad. In periodontal disease, we have plaque control, mechanical or chemical, oral irrigators, dental floors, endodontal cleaning devices, toothbrush, toothpaste, dentifrice, all those things. In this chapter, NRT 5A's regulatory approach, the smoking and smokeless forms. So this was a smaller session. Next session is about we have health education, nutrition, school oral health program, and the very important one, fluorides. So I'll be taking these 4 chapters in my next session. Thank you.